agenda. Welcome everyone to Cancer Center Grand Rounds, and really pleased to have three very esteemed colleagues presenting. And I think if there's one particular theme that I think emerges among many from today's forum is that we have what's really great is the number of talented people across multiple disciplines who are making progress on pivotal questions in cancer care and cancer research. And I think today's forum is just, one very clear of many examples of three individuals doing great work, each coming from a different discipline, but working together towards really making a difference for patients, for the field, and obviously advancing our research and educational agenda. And I'd like to do is really introduce one of our speakers and ask him to then introduce the other colleagues. So let me introduce Kevin Billingsley, who I think, frankly, in the past, 9 months or so, really needs no introduction. Kevin, as many of you know, joined us in or about January as our Chief Medical Officer for the Yale Cancer Center and Smilow Cancer Hospital, and is also a professor in the Department of Surgery. Kevin is responsible for our clinical enterprise, working with our leaders in nursing and other disciplines, and has really done an extraordinary job, and certainly working, arriving here and nothing less stepping into the frying pan with COVID, and really the need to work collaboratively across so many people to execute on what was a heroic and extraordinary response on so many parts. Kevin, beyond his success as our Chief Medical Officer, is an international leader in the clinical care and research of patients with hepatobiliary cancers, as well as gastrointestinal malignancies. Before joining us here, Kevin was a professor at Oregon Health and Science University, where he was the medical director of the Knight Cancer Institute and the chief of surgical oncology. And Kevin is going to take over with our discussion of evolving multidisciplinary management of colorectal liver metastases. And I'll let Kevin take over and introduce the other great faculty. Kevin, thank you.
Charlie, thanks. Thank you so much for that really gracious introduction. I'm thrilled to be here. We're going to do kind of a tag team screen sharing here, and let me see if I can get going with that. Okay, is that working for folks?
I only see you, Kevin.
Okay.
There you go.
Got it.
How about that? Okay. Well, as Charlie alluded to, I've had the pleasure of spending much of my career as a hepatobiliary surgical oncologist. And, I will share that one of the most gratifying aspects of my time in surgical oncology is participating and witnessing the dramatic advances that we have had in the multidisciplinary care of patients with colorectal liver metastases. And one of the things that I was most excited about as I prepared for my transition to the Yale Cancer Center and Smilow Cancer Hospital was the fact that we truly have we essentially have a world-class team of experts across disciplines who are contributing to the care of this unique group of patients. And we have all of the elements here. And I want to, with that as a jumping off point, introduce my two partners in this multidisciplinary grand rounds. Dr. Michael Cecchini is a seasoned veteran of Yale. He's a graduate of the Albert Einstein School of Medicine, came here to New Haven for residency, stayed on for fellowship, and has just continued to rocket to prominence from there. Michael profited, as many of our fellows have, from the mentorship and guidance of Dr. Jill Lacey, who is, as most of you know, the dean of our GI medical oncologist. Michael has carved out a really unique spot for himself in our organization and increasingly across the country in a mix of traditional clinical research in GI medical oncology, as well as phase 1 clinical trial work and drug development. So delighted to have him with me today and as a clinical partner. Next, Dr. David Madoff is a relatively recent addition to the Yale team. When I was preparing for my move here, he was one of the people that I was most excited to partner with. David has essentially written the book on portal vein embolization and optimization of the hepatic remnant in preparation for complex hepatobiliary surgery. He's spent much the earlier part of his career at the MD Anderson Cancer Center, then transitioned back here to the East Coast, where he was at Cornell for a number of years, and then more recently we've been fortunate to recruit him as the vice chair for clinical research and the section chief of interventional radiology. And I will say kind of quickly as a side note, one of the things that I enjoy most about caring for patients with colorectal liver metastases is that it really is a team sport. This multidisciplinary grand rounds does highlight a number of us who are involved from surgery, medical oncology, interventional radiology. I do feel a little remiss in not having some other folks on a panel who are important contributors, such as radiation oncology and other disciplines, but I know we'll have other opportunities. So this is a very comprehensive field. We're not going to cover everything today. Our goal as a team is to kind of give you some broad brush overviews of developments and high points. I will be giving an overview and talking about some surgical strategies, mainly focusing on patients with advanced disease. Dr. Madoff will be talking about his real area of world-class expertise, which is various techniques to optimize the liver remnant to support complex resection, the role of interventional radiology. And Michael will be updating us on the numerous advances in systemic chemotherapy for the disease. Well, the idea of resecting colorectal liver metastases is not new. You know, surgeons have been doing this for 40+ years. What is exciting is the developments that have been made in the safety of these operations, the number of and variety of technical approaches, and the slow but steady increase in long-term survival that patients enjoy after these procedures. Why would we focus on aggressive liver-directed therapy for these patients with liver metastases? Well, as many of you understand, the liver disease in metastatic colorectal cancer often serves as the main source of morbidity and mortality, in effect, the driver of demise for folks with this disease. And this occurs through a number of pathways. Patients with bulky disease can experience liver failure. More commonly, they suffer from progressive biliary obstruction, which is unstentable, untreatable. And once this occurs and they are jaundiced, it is very difficult to provide ongoing effective systemic chemotherapy, and it leads to kind of a downhill spiral. The good news is that from multiple current case series, we know that complete resection of colorectal liver metastases patients can enjoy up to and sometimes more a 50% 5-year survival rate, yet there remain significant challenges. Roughly only 20% of patients with this disease process are resectable at the time of presentation, and even with aggressive surgical therapy, recurrence remains frustratingly high, often 80% at about the 5-year mark. I don't want to steal Dr. Cecchini's thunder here, and I apologize for stepping on his turf, but no self-respecting surgical oncologist would talk about progress in this area without some mention of the groundbreaking advances that have been made in systemic chemotherapy. I think this timeline kind of tells the story. We've gone from the 5FU era, which was the case for many years, as really the only chemotherapeutic option in this disease with a 12 to 14-month median survival, to our current modern regimens with FOLFOX, FOLFIRI, and increasingly triplet chemotherapy, where patients even without surgery are enjoying survival of 29 plus months. So as much as we as surgeons congratulate ourselves on our technical wizardry, a big piece of the progress in the background is effective chemotherapy. So this is what I, as a surgical oncologist, love to see: a patient with easily resectable disease, limited number of tumors, one, maybe two, tumors that are peripherally placed, not in close proximity to major vascular structures. And these folks are amenable to anatomic or segmental resection. The surgical options for managing folks like this are manifold. They can be treated well with a traditional open operation. Laparoscopic liver resection is now in the mainstream, and increasingly we're utilizing the robotic platform to address some of these tumors. Now, more commonly, what we see, particularly at large academic medical centers such as we work in, are patients who have advanced colorectal liver metastases. These are patients with multifocal disease. Often the disease is bilateral on both sides of the liver, and often there are bulky lesions which are in close proximity to major vascular structures or portal pedicles. So I'm going to share the story of a 48-year-old woman who I treated in Portland about 8 years ago. She presented with bulky complex liver disease and a sigmoid, non-obstructive sigmoid primary cancer in place. So not to dwell on too many liver technicalities, but she had a high central liver lesion in close proximity to the vena cava, sitting right under the confluence of the 3 hepatic veins. She had an additional bulky lesion in segment 4 of the liver, sitting in proximity to one of the pedicles and the middle hepatic vein. And then she had another bulky lesion in segment 5 and 6 on the right side of the liver. So this is a perfect segue into the need for multidisciplinary strategies to address patients like this with advanced colorectal liver metastases. And I'm going to talk today in my section about 3 strategies to approach this group of patients, all requiring the integration of multiple disciplines. Probably the most common is what we describe as conversion chemotherapy, which involves the upfront utilization of multi-agent chemotherapy, usually oxaliplatin-based, to downstage tumors within the range of resectability. Another approach that is increasingly used at high volume centers around the world is what we call staged hepatectomy. This is breaking the surgical treatment up into 2 sessions with an intervening procedure called portal vein embolization, which leads to optimization or growth of the planned hepatic remnant. And then the last topic I will touch on briefly is something that many of us around the world are starting to do, which is complex parenchymal sparing resections, which allow simultaneous resection of multiple sites of disease. So the patient I described did go on to have 8 cycles of FOLFOX with bevacizumab Avastin, and she was in the subset of patients who enjoyed a stunning response. As you can see, the central lesion shrunk dramatically. You can start to see some width on the IVC, a little more space around the hepatic veins. This lesion is now shrunk away from the left portal pedicle, involves the caudate lobe of the liver, which is a bit of a tricky place to operate, but now has good clearance of the left pedicle. Segment 4 lesion significantly smaller, and the right-sided liver lesion also smaller. This allowed us to take her to the operating room in one operative setting, treat her with a left hepatectomy, a caudate lobe resection, a segment 6 resection, and a sigmoid colectomy. This was her disease as it appeared in the operating room: stomach, liver, gallbladder, and the caudate lesion shrunken and partially calcified. The segment 5-6 lesion, again, nice response, partially calcified. And what she wound up was this complex bilateral resection, but with plenty of good, healthy liver remnant left. And I know everyone reports their greatest success. What happened with this lady is she had a single site of recurrent disease about 2 years after that we treated with a little wedge resection, and she is disease-free at last follow-up about 8 years out. So what we've learned over the years, and the French are really led the way in this, is that patients can enjoy, even after chemotherapy conversion, can enjoy a very high rate of long-term survival. This is data from Renee Adam, now presented years ago, but makes the point. They looked at their subset of patients from their entire spectrum of liver metastases who were resected after conversion chemotherapy. And although this group of patients who were converted to resectable did not enjoy the survival that the primary population did, 33% 5-year survival in a subset of patients, extending out into the 8 to 10-year mark, as my patient did. At OHSU, while I was there, my partner Sky Mayo and I took a kind of a new is old or old is new approach to kind of optimizing this approach. We started a hepatic arterial infusion program. As many of you know, this involves the placement of a chemotherapy pump and a catheter into the hepatic artery to deliver focused chemotherapy with the aim of converting patients. It's a complex operation that involves dissection of the hepatic artery, placement of the pump in a subcutaneous pocket with installation of FUDR. We did this in combination with systemic chemotherapy with FOLFOX. I'm just going to quickly report these results. We placed about 27 pumps at this time. We analyzed data. We looked at the first 22 of these pumps, all a subset for unresectable disease. Many of these were high-risk disease, 36% with a KRAS mutant, all had synchronous disease, all had multiple liver lesions. The point relative to this talk that I'd like to point out is that of the 13 patients that we were aiming to convert to resectability, a subset we were able to eventually get to the operating room with very extensive bilateral disease. So this is yet another kind of regional chemotherapy strategy to convert patients to resectable. Another approach that is done throughout the world that is facilitated by David's work is a 2-stage hepatectomy. This is for patients with complex bilateral disease. They go to the operating room in one session and either have resection of the left liver disease or ablation. Then they go on to portal vein embolization, which leads to hypertrophy of the left liver, and the remainder of the disease is resected in a second operation. And this is a strategy that allows us to treat what can be otherwise completely unresectable disease. So series from around the world do demonstrate that even for patients with advanced bilateral disease, if we can complete the 2-stage resection, we can provide patients with excellent long-term survival. There is always going to be a subset of patients who drop out due to progression between the operations or in the course of therapy, And unfortunately, those folks don't do well, but this is a great strategy to get patients to the operating room. One of the things that I and a number of other surgeons have started to do in recent years is exploit the concept of the R1 vascular margin. This is related to the fact that there is going to be a subset of patients like this who have bulky tumors and the disease is in close proximity to a major vein or portal pedicle. But it is possible if you can get a wide resection margin on the rest of it and get a very narrow margin that's positive only on the vein to get excellent local disease control in that part of the liver and still preserve significant liver parenchyma. My friend, Dr. Guido Torzilli in Milano, has been kind of the primary proponent of this. And I think that this is a strategy that is gaining traction in many HPB centers around the world. Guido and his team have reported their experience. And one of the things that I think is striking is that patients who you compare their survival when you compare R0 resection with R1 resection from the liver parenchyma, there's clearly a decrement in survival. However, the group that have an R1 margin only on a vessel have a survival that is virtually identical to those that are R0 resection. I think that this is a great example of a theme that we see across surgical oncology and multiple diseases. Breast cancer, the most notable here, where we over time have gone to a multimodality approach involving chemotherapy, radiation, and much more limited surgery, going from radical mastectomy to breast conservation, now moving towards even eliminating the axillary component of breast cancer surgery. Same in head and neck, laryngeal preservation, possibly preservation of the rectum in rectal carcinoma, sarcoma, esophageal cancer. The theme is consistent throughout. Integration of multimodality therapy allows a more conservative operation, and I think we're getting there. Liver cancer. This was one of my cases from Portland, not a great picture, but a patient who I took care of who had multifocal disease in the upper part of the right side of the liver and left liver, requiring resection down onto the hepatic veins and right portal pedicle, kind of a wedge resection on the left side, all able to do this in a single operation. The greatest thing about this is that all of these strategies do require multidisciplinary care and integration. As I take off my surgeon hat and put on my CMO hat, all of these strategies come together in the fact that our aim at the Yale Cancer Center, through both our care signature effort as well as our multidisciplinary disease teams, is to create a wraparound set of services for our patients. As I mentioned, it's not just liver surgery and medical oncology and interventional radiology. We need to coordinate care for many of these patients, including radiation therapy, imaging, including nuclear medicine, of course, oncology nursing, pathology, social work. Our colleagues in colorectal cancer surgery need to be involved, and genetics. And I think that's the promise and fun of what we're doing. So I'd like to hand off now to Dr. Madoff. Thank you, David. I guess I need to stop my screen sharing.
Share my screen here. And okay, so can you all hear me?
Yes, we can hear you.
So what I would first like to thank Charlie and Kevin, as well as Mike, for giving me the opportunity today to speak at the Yale Cancer Center Grand Rounds. As you may recall, I did discuss this topic of liver regeneration last December, but today I will be focusing on how these techniques relate to optimizing the anticipated future liver remnant prior to resection in patients really with only colorectal liver metastases. I'm very happy to be here in terms of the fact that this is, like Kevin said, this has really been my life's work and passion, and having the opportunity is for me very, very nice. So As you just heard from Kevin, there have been tremendous advances in hepatobiliary surgical techniques such that death is now considered rare. However, complications such as fluid retention, cholestasis, and impaired synthetic function still contribute to prolonged recovery times and extended hospital stays. This is particularly true in the setting of an extended hepatectomy where 5 or more node segments are removed. And in fact, as you can see, the mortality in this setting can approach 8 to 10%. Now, as can be seen from this French study, there's a direct correlation between the number of overall complications and the size of the liver remnant. And this is not in regards to the severity of the overall complications, but really only the complication rate. So at this time, there's really no limit to how small a liver remnant in order to reduce the morbidity of hepatic resection, at least 20% must remain in patients with normal underlying liver. That is, for example, patients that have colon cancer, mets to the liver without ever having touched chemotherapy. 30% in injured liver, such as those that have had extensive chemotherapy or steatohepatitis, and 40% in those with underlying cirrhosis. So there's many preoperative strategies to prepare the liver for resection. And these include portal vein embolization, which was briefly discussed by Kevin, radiation lobectomy. There's an ALPS procedure that we'll get into briefly, and also something called liver venous deprivation. So portal vein embolization is the original strategy first described by Professor Mikuchi's group from the University of Tokyo in 1990. It's been used to redirect portal blood flow to the future liver remnant, or FLR, and by doing so, can initiate hypertrophy of the non-embolized segments. And by doing this, we can reduce the number of overall perioperative complications and increase the pool of potential surgical candidates who have what we call marginal anticipated future liver remnant volumes. Please note that the goal is really not to improve the overall survival after resection as compared to those that did not require PVE. It's just really to achieve similar survival rates to those patients who want to undergo surgery that did not actually require PVE. And until recently, the general consensus was that PVE was the standard of care at most hepatobiliary centers worldwide for safe and effective generation or regeneration of the FLR. It's now been over a decade since the first meta-analysis of the usefulness of PVE was published, and in this study, they reviewed 37 publications with over 1,000 patients and found that PVE is safe with a low mortality and morbidity rate. Further, 85% of the patients were able to get their proposed surgery. However, as you can see down here, is that there was a substantial group of patients that were not resected, and this was due mostly to disease progression or insufficient hypertrophy. As stated previously, the goal of PVE in the setting of colorectal cancer is to get similar survival rates to those patients who did not require PVE. Here we see two actually French studies, and pretty old, that actually showed where these outcomes were borne out. Now, PVE not only causes the liver to hypertrophy, but it also results in improved function of the FLR. And this has been shown by nuclear medicine studies with the lobar function shifted from the embolized to the non-embolized liver after PVE. Further, in patients with hilar cholangiocarcinoma who've had biliary drainage catheters, more bile is produced in the non-embolized liver than in the embolized liver. And lastly, we can see that less alterations in liver function tests after resection occur following PVE than in those in which PVE was not performed. So for decades, CT has been the cornerstone for surgical planning. And when assessing the FLR, we do our calculations based only on the size of the liver remaining. CT does directly measure the future liver remnant, and the total liver volume is not actually measured, but rather it's estimated from the association between the liver and patient size. And this is based on body weight and patient's body surface area. Or a larger patient would need a larger liver, a smaller patient may need a smaller liver. The FLR to total estimated liver volume ratio can then allow for uniform comparison of FLR volume prior to resection, whether or not PVE was performed. And this is the formula, which is based on a linear regression equation from over 500 Western adults. It's critical to understand that the denominator does not change on the pre and post CT scans because it is an estimate. One must realize that PVE does cause atrophy of the embolized segments, so there have been cases where the total liver volume is directly measured and went down after PVE. Therefore, even if the numerator is unchanged, the FLR percentage may inadvertently increase, giving one a false sense of belief that hypertrophy did occur. And unfortunately, patients have died after surgery when this happens. So if we look at this patient with colorectal liver metastases, here we see approximately 4 weeks later that the FLR grew from 17 to 30%, or a degree of hypertrophy of 13%. This patient also had a kinetic growth rate of 3.5%, which is a good indicator, and this will be discussed in much more detail in a little bit. In recent years, there's actually been controversy as to the appropriate limit for resection, and this may depend on the institution and the formula being used. In Europe, for example, 30 is used as the cutoff for the need for PVE. That said, we showed during my time at MD Anderson that there are statistically significant differences in outcome, whether it be from liver insufficiency or death, if you have less than % FLR. However, no differences were found once you had more than 20% of your FLR remaining. And further, we wanted to see the impact of PVE in the patient population, and we found that in those patients that had at least 20%, meaning that they already either had 20% not requiring PVE or had 20%, and in those days we did it with a higher future liver remnant to see if there was any difference, and we compared them to those patients who had less than 20% and actually had at least 20% and did not require PVE, and compared them to those also that did not have 20% and needed PVE. And we found that as long as the patient after PVE at least 20% of their future liver remnant, there really was no difference in what happened after resection. So we talked about degree of hypertrophy a little earlier. So what is the degree of hypertrophy? Well, it's the post-PVE FLR minus the pre-PVE FLR, which gives you a dynamic measure of liver regeneration. And this is important because there's an amount of hypertrophy that is necessary to reduce the complications. In our study published from MD Anderson in 2007, you can see that those patients that had more than 5% degree of hypertrophy had significantly less complications than had more than 5% FLR. So here we have a tale of two livers. One patient with cirrhosis and HCC who underwent a right hepatectomy, the other with colorectal liver metastases and only had 5% steatosis who underwent an extended right hepatectomy. Here we see that the cirrhotic patient had excellent hypertrophy, while the other patient had only 1% growth. Interestingly, the cirrhotic patient did well after surgery, while the patient that had the normal liver, or what we thought was a pretty normal liver, actually died after their resection. Therefore, if we see that, you can use these numbers to see that patients that have at least 20% FLR and at least 5% degree of hypertrophy had a 0% 90-day mortality. And like I said, this information can be used when trying to understand whether a patient should be indicated for their resection after PVE. So now that we know the FLR cutoff numbers, that is 20% for normal liver, 30% for injured liver from chemotherapy, and 40% for cirrhosis, and we know the degree of hypertrophy of 5%, is this enough to really be able to predict which patients should have their surgery? So we now know that the degree of hypertrophy is based on the timing of the imaging, and that a true assessment of the FLR growth is difficult to compare among patients. Therefore, we developed a new variable called the kinetic growth rate, or KJR, which is the degree of hypertrophy over the time elapsed from PVE in a number of weeks. So here we see 3 patients with colorectal liver metastases, each with a degree of hypertrophy well within the amount needed for successful, safe resection. However, the patient on the bottom actually died from liver failure after resection. So we went back and reviewed the cases and found that the time for the first 2 patients was 35 days to get these results, while we found that the patient that died, it actually occurred in 70 days. So when we went back and calculated the kinetic growth rate, the patient that died had only 0.3% per week, while the other 2 had much higher growth rates. Therefore, when assessing patients which should have surgery, we found that in order to really be safe, that we really need 2% per week that led to no hepatic insufficiency or 90-day mortality. So as Kevin stated earlier, we can now extend the boundaries for safe resection by using advanced surgical strategies such as the two-stage hepatectomy, like for this patient, lobar colorectal liver metastases. This patient first had systemic chemotherapy with excellent response, then had surgery to clear the left lateral liver. The FLR volumes were calculated to be 16%, so PVE was performed, and then FLR was then found to be 26%, so the definitive resection was then performed. So to assess the benefit of the two-stage hepatectomy, we reviewed patients who had the advanced strategy with extended hepatic resection and compared those to those that did not have tumor in their FLR, therefore not really needing the second stage. So our results had shown that there was no difference in overall and disease-free survival in those patients that required the two-stage hepatectomy as compared with those that only required the one stage. And as Kevin showed from our study from MD Anderson, in a really highly selected patient cohort who did complete the second stage, we were able to achieve a 60% 5-year survival, which was really considered amazing at, about a decade ago, given the bilobar nature of the disease. However, there is some concerns regarding PVE. One of the major concerns is the potential dropout of up to 35% of patients due to an insufficient FLR or tumor progression within the 4 to 6 week waiting period from the PVE to the definitive resection. Therefore, other approaches are needed. So one issue that has been entertained has been that PVE can lead to expedited tumor growth. So to that end, the recent data supports that we can use chemotherapy during the waiting period and also can be used within the postoperative period, which at one time was thought to maybe limit regeneration. However, that has not borne out to be the case. So there are other alternative approaches that we can use as interventional radiologists. This is a study that was performed from Korea where PVE did not lead to sufficient regeneration, and a Korean group found that later performing right hepatic vein embolization, in addition to the PVE, as shown here, actually result in better outcomes. We have also used something called radiation lobectomy. This is done by the transarterial lobar administration of Y90 microparticles, which is now an established means of providing local tumor control within the liver. That said, there was an unintended phenomenon of contralateral liver hypertrophy, and in several retrospective studies, contralateral hypertrophy occurred from 21 to 47%, and therefore this has been suggested as an alternative to PVE with the benefit of local tumor control and the test of time. So we had talked about this earlier with nuclear medicine as showing improved liver function after PVE. In this small study of 13 patients, with some being colorectal liver metastases who underwent some nuclear medicine scintigraphy, they showed that using radiation lobectomy actually can cause changes in regional liver function, and this correlated with the functional liver absorbed doses from Y90 and PET. And then in 2014, a group from France compared 141 patients who underwent right PVE with 35 patients who underwent radiation lobectomy at 2 centers that were matched for criteria known to influence liver regeneration after PVE. So radiation was performed if the authors found the case to be challenging for PVE. And to be honest, I'm not sure why this would be, but when they matched the patients, they found significantly more hypertrophy after PVE. They concluded that while the hypertrophy from radiation lobectomy is substantial and does minimize tumor progression, PVE can induce significantly greater hypertrophy than radiation lobectomy with these therapeutic doses. So how do you decide if you should use PVE or radiation lobectomy? The decision should be based on the treatment intent, such as, is the patient a candidate for resection now, and what is the planned resection? If the resection should be done now, you should just go ahead and perform the PVE. You also need to know what type of malignancy the patient has and whether the patient has underlying liver disease. In cases where patients have bilobar colorectal metastases that require a 2-stage hepatectomy, there is likely really no role for radiation lobectomy. As you can see, I am personally not in favor of the radiation lobectomy in this approach, as you would really need to do Y90 of both lobes. And it seems appropriate in the setting of HCC with cirrhosis, but I don't think it really is appropriate in the setting of colorectal liver metastases. Another approach is ALPS, which is short for associated liver partition and portal vein ligation. This approach was proposed to replace PVE with 2 surgeries. You perform intraoperative right portal vein ligation, followed by completely devascularizing segment 4 of the liver, and at the same session, the surgeon clears the FLR of the tumor. The patient is then closed with the tumor-bearing liver in place while the FLR rapidly hypertrophies, and then the surgeon returns within 7 to 10 days for a second laparotomy to complete a definitive resection. And early reports actually showed very strong tumor growth, FLR growth, and was believed to have a lower risk for tumor progression. That being said, when comparing PVE to ALPS, there was a massive and faster hypertrophy in the ALPS group, but it came at a much higher cost of major complications and death. Interestingly, while the kinetic growth rate was found to be higher, electron microscopy studies from Japan showed that the hepatocytes were not mature and not really able to handle the increased blood flow to the FLR. Therefore, it was shown that it is not simply regenerating the liver rapidly, but also in a way that allows the hepatocytes to mature and function appropriately. So interestingly, a systematic review and meta-analysis for colorectal liver metastases was performed, confirming the findings of the faster kinetic growth rate with ALPS, but with the increased morbidity and mortality. So for this reason, numerous modifications have been proposed, many of which negate the distinct advantages of why ALPS was proposed in the first place. And lastly, I want to just show a new procedure, one that we will now be using at Yale. While I already showed sequential PVE and hepatic vein embolization, liver venous deprivation is performing PVE and hepatic vein embolization in a single session. The goal is to shorten and optimize the phase of liver preparation before surgery without the aggressive nature of ALPS. And in this early feasibility study from 2016, the procedure was found to be safe and feasible in a small patient cohort of only 7 patients. And then the same group then added embolization of the middle hepatic vein to the right hepatic vein embolization. And they found that by doing so, they can get safe and provide the most marked and rapid elevation in hypertrophy and liver function, unprecedented for an IR procedure. And just soon, Kevin and I will be the co-PIs for a Yale prospective clinical trial looking at liver venous deprivation called Dragon 1 and Dragon 2. Dragon 1 is a feasibility study, and Dragon 2 actually will compare it to the standard of care, which is PVE. So in conclusion, liver regeneration is critical to managing colorectal liver metastases, and as I hope to have shown, there are numerous strategies that can regenerate the liver, either percutaneously or by surgical means. Currently, the understanding of liver regeneration in this area is really at its infancy, and ample opportunities do exist for research. So I'm looking forward to working with your team. I'm looking forward to working with Kevin on this Dragon study, and thank you for your attention.
Thank you, David. That was awesome.
Thanks.
Dr. Cecchini.
Kevin, David, can you stop sharing? Okay,
I'm trying to stop the sharing here.
Yeah, got it. All right. So I'm Michael Cecchini. I'm a medical oncologist, and I'm going to talk about the chemotherapy in the perioperative management of these liver metastases for colorectal cancer. So first, I'm going to talk about the molecular profiling that's important to decide chemotherapy agents, as well as sidedness, which is not truly molecular profiling, but certainly has an impact on the chemotherapy selection. The two types of patients we encounter, the unresectable patient, the resectable, biologics, and then some of the damage our agents can do that can complicate the role of, can complicate the surgery. So molecular profiling for colorectal cancer, what information do I really need to know to make a chemotherapy decision? The RAS and the RAF status are very important, and they have been for some time. Mismatch repair status, microsatellite status, which is analogous to that. And then the sidedness has become increasingly important for determining which biologic to use. So the origin of the primary tumor, was it a left-sided tumor or a right-sided tumor? So to remind ourselves why RAS and RAF status is so important, we need to go back to the EGFR pathway. So EGFR here in this purple is upstream of KRAS, BRAF, MEK, ERK. So in a RAS mutated cancer or a RAF mutated cancer, this pathway is constitutively activated below the level of the receptor. We have drugs, cetuximab and panitumumab, two monoclonal antibodies that target the EGFR receptor that we add on to chemotherapy. So they're effective if this pathway is not constitutively active below it. So in a RAS wild type or a RAF wild type, we add on panitumumab, a humanized monoclonal antibody, or cetuximab, a chimeric antibody. But for the patients that are mutated in RAS, we have to take a different approach. So bevacizumab, Kevin talked about a little bit. It's a monoclonal antibody against VEGF, vascular endothelial growth factor, and that's also added onto chemotherapy. BRAF has become important just in the last couple of years. Now we have targeted agents for that, encorafenib and cetuximab. But for the intensive purposes of this talk, BRAF is used as a negative prognostic mutation, and most of those patients are not going to be included in the consideration of surgery. So why is the mismatch repair status so important? So to answer that, we first have to remember what mismatch repair proteins do. So MLH1, PMS2, MSH2, and 6, these are the four most clinically relevant mismatch repair proteins. Their function is to follow the DNA polymerase machinery along. As it undoubtedly makes some mistakes, it fixes these single base mismatches, which are most prevalent in these areas called microsatellites, which are dinucleotide and trinucleotide repeats across the genome. You can imagine this DNA machinery gets really caught up on all this repetitive DNA. Lots of mistakes are made. So we know when these are lost, tumors have a very high tumor mutational burden, which leads to a lot of neoantigens. We've known for some time that these are some of the most sensitive cancers to immunostimulatory therapies, such as anti-PD-1 and anti-CTLA-4 therapies. So they've been approved in the refractory setting for a few years, but only recently, just a few months ago, did we get to see their activity in the first line setting. You can see very dramatic separation of these two curves here. Green being pembrolizumab, purple being the chemo arm for a first-line microsatellite instability high colorectal cancer. I mean, if we look at the 2-year mark here, you're seeing 48% of patients that are microsatellite instability high are progression-free and alive at 2 years versus only 19% with chemo. But for today's talk, what's really important to actually look at this part of the curve on the far left, because that's where anybody that's going to surgery would be. They'd be early on in their treatment journey. And you can actually see pembro behave a bit more inferior to chemotherapy in this setting, and a very rapid drop off, even with pembro, which obviously has a tail on this curve. So immunotherapy in the neoadjuvant setting for somebody that's initially resectable, for example, is definitely not ready for prime time. And I think future directions will certainly be chemoimmunotherapy, and hopefully will negate some of that early drop off. Why is sidedness important? So we've known for some time that hindgut, that the left-sided colon is of different embryologic origin than the right colon. So hindgut for left and midgut for right. Right-sided tumors, generally worse prognosis, more methylated tumors, higher BRAF, to some degree higher KRAS, and left-sided the more traditional APC mutations and TP53 mutations. We know that even if you're RAS wild type, it matters whether or not you respond to a EGFR antibody such as panitumumab or cetuximab. So it's really the RAS wild type left-sided tumors that we're thinking about using these drugs in the first line setting. And even if RAS wild type and right-sided bevacizumab should still be considered. So what are the drugs that we have at our disposal to help these patients? So Folfox, we've probably all heard Folfox, Folfiri, Folfoxiri. And when we use it in pancreatic cancer, you hear FOLFIRINOX, but they're slightly different approaches. So what is Folfox? So 5-fluorouracil, which is patented by Charlie Heidelberger, I think in 1957, and is still around and going strong. Is a thymidylate synthase inhibitor, so you don't have thymidylate around for rapidly dividing cells. Leucovorin potentiates the activity of 5-FU. It's a vitamin that we give along with the chemotherapy. Oxaliplatin is the oxin in Folfox, and that's a platinum agent that causes DNA adducts and ultimately results in double-stranded breaks. And irinotecan, which is the IRI, and Folfiri is ultimately converted into its active form, a topoisomerase 1 inhibitor, SN38, and ultimately also end result is double-stranded breaks. So these are the main agents we have. We started out, again, with just 5-FU, and this is about what we were doing back in the early 90s. So we had about a median survival of 12 years for patients with metastatic cancer. When we started to have doublet chemotherapies in FOLFOX and FOLFIRI, we moved this out to about the 2-year mark. Now we're really between the 2 and 3 year mark for median overall survival for most of our active trials with colorectal cancer. With FOLFOXIRI, the triplet combination that's a bit more toxic and reserved for younger patients is about a 32-month median survival. So we have to ask ourselves at Tumor Board, what does this patient have a pathway to cure? So what are our main goals with chemotherapy? We've heard a little bit about conversion therapy, so converting the unresectable patient to a resectable patient. If we have a patient that's upfront resectable, chemotherapy can still be useful to reduce the surgical complexity, eradicate micrometastatic disease, which it's also hopefully doing for the unresectable patient. And then also assess the biology of the aggressiveness of the disease. Is somebody actually getting a response from chemotherapy, or are they just rapidly progressing? That's not a patient you'd want to take to surgery anyway. And if we know that even in the best of circumstances, the patient's never going to get to a surgical option, the treatment is prolonging life, hopefully by controlling disease and improving tumor-related symptoms. So we should think about this as 2 groups, the unresectable patient and the resectable patient. So the upfront resectable patient, and just there's no right way to integrate chemotherapy into these patients, by the way. Different centers take different approaches, and there's more nuance than just this slide. But when to consider upfront resection, generally for fewer liver metastases, chemotherapy response, not really, the surgeon doesn't really think chemotherapy response is going to lower the complexity of the operation. But when do we do it? When there's more than 4, a suspicious nodal involvement, bilobar disease. But again, there's more nuance to this. So we have to take everything, every aspect of the patient into account. Do they have a lot of other comorbidities where if they're not tolerating chemotherapy well, we're expecting significant increase in liver damage, which could complicate an operation? Is there reason to suspect that they have particularly aggressive disease, and you want to give them the tincture of time on chemotherapy to make sure they're not just rapidly progressing and you're going to put them through an unnecessary operation? Did they recently receive FOLFOX for management of their primary? And could a slight response result in maybe converting an open resection to a laparoscopic resection? So what chemotherapy do we typically use? So again, these are patients that could be resected, most likely. So FOLFOX, a doublet chemotherapy, perhaps with a biologic, bevacizumab, panitumumab, or cetuximab. But the important part is to limit the number of chemocycles as much as possible. These are patients that can get to surgery quickly and should get to surgery quickly, and we want to do as little damage as possible to the liver with our chemotherapy. So we should image patients early, and as soon as it's feasible, these patients should be taken to surgery. We generally plan to do 6 months total of chemotherapy, but the rest would be reserved for later. So what about the unresectable patient? Now, this patient can't get to surgery without a response. So it's a different approach. So we talked a little bit about what is unresectable, but so how likely is this unresectable patient going to be able to get an operation? Perhaps as high as a third of the time that we would get enough sided reduction to convert this patient to resectable. But what regimen is best? Again, if you look at guidelines, both guidelines are so the NCCN guidelines don't really take much of a stand. They say FOLFOX, FOLFIRI, panitumumab, bevacizumab. They kind of leave it up to the treating oncologist. ESMO, on the other hand, takes a more dogmatic approach and says FOLFOX is the recommendation. Or for unresectable metastases, consider FOLFOXIRI. So that's the approach that we would take here, predominantly in the United States, that most centers would do, but certainly here at Yale. For the younger fit patients, we would be for an unresectable patient, we would do FOLFOXIRI for plus bevacizumab. But for our upfront resectable patients, we would again just be doing a doublet. So I'm going to skip through this in the interest of time, especially since Kevin showed some of those slides already. So what about our biologics? So this is another level of nuance, again, to our chemotherapy here. So we have agents such as bevacizumab, which is a vascular endothelial growth factor, antibody against vascular endothelial growth factor, which is secreted by the tumors and stimulates blood vessel growth because the tumor needs increased vascularity. So we know that bevacizumab increases response rates, but it can potentially increase perioperative complications. We see vascular events such as arterial thrombi, venous thrombi on occasion, perforations, but the big concern is wound healing. So we generally would hold bevacizumab within 6 weeks prior to any surgery. There is some data that supports it up to 4 weeks prior to surgery, but the concern is when do you hold it perioperatively? So this has actually been looked at, the addition of bevacizumab in systemic therapy for unresectable liver metastases. So we have a cohort of patients here split up into two groups. These are all KRAS mutated patients, so patients that are perfect fit for bevacizumab. So FOLFOX plus bevacizumab in arm A and FOLFOX alone in arm B. You can see that the resection, the rate of R0 resection, complete resection, 22 versus about 6% without the bevacizumab. So very, very big difference about getting to surgery there. What about progression-free survival? About 9.5 months median versus about 5.5 months median, favoring bevacizumab in blue here. Same thing with overall survival, less striking difference, about 25 versus 20 months. Both are statistically significant. So bevacizumab should be used in the perioperative management with FOLFOX for KRAS mutant liver metastases. What about the EGFR antibodies? These are highly effective therapies for patients that are KRAS wild type. You'd think we'd see a similar story here. In fact, we're seeing the exact opposite. So again, we have two groups here. This is a new EPOC study split into chemotherapy perioperatively, before and after surgery, with cetuximab and without cetuximab. And so without cetuximab is here in blue. And this progression-free survival curve here. So you can see the red group, chemotherapy plus cetuximab, doing inferior to the chemotherapy alone group. Same thing with overall survival. What's really interesting, if you look at these curves, these are the times of surgery. So these curves have not separated. They separate later. And an obvious explanation would be this, would be, and cetuximab is creating some increase in perioperative complications. That's not the case. And the fact that the changes in progression-free and overall survival happen later, again, speaks to that it's not an actual increase in perioperative complications. Frankly, I haven't seen any good explanation for why this why we're seeing these confusing results. But I think we should proceed with caution when using our EGFR antibodies in the perioperative setting. I think a lot of my colleagues have not bought into this. And I am, again, uncertain as to the biological rationale of why we're seeing this. But it's a very striking overall survival difference. It's almost 3 years median overall survival difference without the antibody. So chemotherapy-associated liver disease is what I'll close on. So our drugs can do damage. That's why that our approach is to limit the number of cycles when feasible. So oxaliplatin can cause hepatic sinusoidal abnormalities. You can see the dilations here in white of these sinusoids directly from oxaliplatin. You can see nodular regenerative hyperplasia, this like lighter pink nodule here, crowding out the more healthy liver tissue here, which creates non-cirrhotic portal hypertension, both from oxaliplatin. Whereas irinotecan can cause steatohepatitis, so fatty infiltration and inflammation of the liver here, a very severe case and a less severe case, but frankly, there shouldn't be fat in either of these images. So in conclusion, we talked about the importance of molecular results. Those are things that need to be sent on every patient so that the medical oncologist can know what treatment approach should be done, the role of sidedness, our approach to the unresectable and the upfront resectable, and some of the damage our agents can do. Thank you so much.
Michael, thank you for a high-speed yet incredibly comprehensive overview of a rapidly evolving and complicated field. And David, I want to thank you as well. Given the time, I don't think we have much left over for discussion. I would just close by saying that this is an incredibly exciting field to work in. I think the overview that my partners have given gives the audience a sense of the enormous complexity yet opportunity involved for our patients. And I think for all of us who work together, it is yet another call for an extraordinary level of teamwork, integration, communication. All of these clinical services have to be linked together by meticulous communication between us as clinicians, as well as our nurses and administrative staffs, as we kind of navigate care throughout a very complex system. Charlie, anything to add?
Oh, I just want to thank David, Michael, and Kevin for really just a brilliant discussion. And thank you for your leadership, your collaboration, and building a team around a pivotal area of care and research. And thanks everyone for joining us, and I think giving us a lot to think about and really exciting progress.